Welcome to this episode of Orthodontics in Summary. In today's episode, we'll be updating on retention. I'll be exploring the current literature and what the recommendations are from it in terms of our clinical protocols. We'll look at what is stable in terms of retainers and what is unstable, both fixed and removable. We'll also get deep into the failures that take place with different types of retainers. And at the end, we'll conclude with current recommendations that have come about from clinical practice guidelines and the current evidence. And there will be a whole host of clinical pearls that I'll be sharing with you as well from the two excellent lectures which this podcast is based on, which is Marie Cornelis' lecture and Simon Littlewood's from this year's British Orthodontic Conference. What is stable and what isn't stable? It's a story of two halves. In terms of the maxilla, we tend to find that both fixed retainers and removable retainers tend to be equally stable, and that's Berging's study from 2015. Does it make a difference if the fixed retainer is from canine to canine or from lateral incisor to lateral incisor? Well, it looks as though it isn't making any changes. That's Nagragi's paper from 2021, which looked at a 2-year follow-up and found only a 2.4 degree difference. Whether it's full-time or part-time removable retainer. Well, there is no difference between those two in terms of clinical outcomes, and that's Gill's 2007 and Thickett's 2010 paper. The mandible, though, is very much different. Initially, there are no differences between bonded and removable retainers. That was Littlewood's study from 2023, but that changes quite dramatically. We start to see changes edging their way at the 12-month mark. Then at 24 months, there's a significant difference between fixed and removable retainers, favouring the fixed retainer by 1.5 millimeters. When we get to 4 years, that difference grows even larger. That's Magrabi's paper from 2018. Now, it was interesting to find out at the 4-year follow-up, both had some elements of relapse. In terms of the fixed retainer, it was 1.2 millimeters. In terms of the removable retainer, it was 3.1 millimeters. This is owed mainly to compliance, where we understand that 2/3 of patients aren't necessarily following the regime they've been recommended at the time of removal of appliances. What factors influence lower mandibular alignment? Well, a 9-year follow-up study by Cornelis in 2023 showed only 2 prognostic factors, and that was the presence of excellent alignment at the end of treatment. The better job we do, the less failure that takes place. But on top of that, the only other prognostic factor was the presence of a lower fixed retainer. In terms of failure, well, what fails? Ultimately, everything does. But in terms of retainers, we know that fixed retainers fail more than removable retainers. In terms of just looking at removable retainers, full-time fail more than part-time. That was Millett's paper from 2007. In terms of a removable retainer, which is plastic, versus a Hawley retainer, greater failures take place with removable plastic retainers. We find that when it comes to plastic retainers, at the 12-month mark, the average failure is around 35%. This is from Bilinska's study from this year in 2025. Interestingly, they followed up for 2 years, and at 24 months, there was a failure rate of 63%. And that was mainly down to occlusal wear, which caused the failure of the retainer. What about fixed retainers? Well, a systematic review from 2 years ago from I and Ahmed a trainee who I studied with many moons ago and has achieved great things now in orthodontics, showed in his systematic review an overall failure rate of 35%. Now, that changes as far as the duration of time goes. Majority of those failures are actually within the first 6 months at 24%. Then over 1 to 4 years, that increases to 41%. And I think what's key to take home is that at 5-year plus mark, around a failure rate of around 53%. 1 in 2 bond retainers have failed at that time point. Is there a difference between the maxilla and the mandible? Well, according to this systematic review, there is no difference in terms of failure rates. Approximately 1 in 3 of them do fail. Where do the breakages take place? Well, it's different between the maxilla and the mandible. In the maxilla, the fixed retainer tends to break between the lateral incisor and the canine, and that was from Simon Littlewood. In terms of the mandible, it's different, where we tend to find it's the lower incisors where breakages occur. That's from Ahmed Johal's randomized control trial published this year in 2025. In terms of timing of the fixed retainer failure, we know it occurs generally speaking in the first 6 months. But why is that the case? And there's two hypotheses that are put forward here. First by Simon Littlewood, where he describes it's most likely to be an operator error. Moisture isolation, when it comes down to our bonding protocols, seem to be a significant factor. Marie Cornelis had a different outlook on this, and she described how this is a period where we have the greatest mobility of the incisors before they stabilize, just post-treatment, and that can cause a failure to take place of the interface between the actual wire and the composite itself. In terms of the design, are there any designs which are more favourable when it comes to a survival of a bonded retainer? In terms of the Maxilla, the gold standard is a canine to canine bonded retainer. However, that is usually challenging with a lack of inter-occlusal clearance. So it was great to see both Simon Littlewood and Marie Cornelis agreeing and saying that generally speaking, a lateral to lateral incisor bonded retainer is the only thing which is pragmatic and practical to use. What was interesting is that Nagaragi's study showed that even with extended to the canine to canine, there didn't seem to be any significant clinical difference in terms of rotations. What about the mandible? Well, the recommendation is canine to canine. Now, I do remember coming across this concept of bonding premolar to premolar, especially for extraction cases. And Marie Cornelis gave a really good description for this, how that after the first year, extraction sites may open up. However, from the first year to the 5th year, they generally tend to close or reduce spontaneously in the mandible. So it isn't necessary to go premolar to premolar in extraction cases. What about the materials that we have? Well, there's 4 that are available on the market, or 4 different varieties. There's a standard braided stainless steel. We also now have the nickel titanium wires, which are made through CAD/CAM technology. We also have the flat stainless steel, and we also have alloy. So where did these stand? When it comes to looking at braided stainless steel, the wire dimension is significant. The larger, the better it seems to be, with an 021 braided stainless steel offering less failures at 12%, and that's Takken's 2010 paper. The smaller the wire, the greater the failure. When it comes to 3 strands versus 5 strands, there's a 3 to 4 times greater failure for the fewer strands. So stick to a larger wire and stick to one with more strands. What about CAD/CAM and nickel titanium retainers? The idea here is that they're able to respond and to restore the alignment due to the properties of nickel titanium's shape memory. Well, when it comes to looking at their failure rates, they seem to be as much as they are for braided stainless steel at approximately 40%. In fact, one UK study showed almost 50% failure with them. So there seems to be a significant challenge in this point in time in getting the nickel titanium bonded retainers to remain stable. In terms of different designs of stainless steel wires, there's also the flat rectangular wires. Orthoflex is one of those varieties. Now, Ahmed Johal did a randomized controlled trial, looked at this wire over 2 years. To recap, this is a very flat wire. It's an 0.3 by 0.1 rectangular flat wire. Now, the advantage of this is that it has the ability to be adapted chair side and be relatively passive. He found an exceptionally high survival rate at 2 years. I think the challenge with this particular study is that there was exceptionally high survival rates for also multi-stranded braided stainless steel, as an expert user was carrying out the trial itself. Blue alloy has had its day, and a bonded retainer going from canine and canine only, not bonding any of the incisors, has the greatest failure rate of 32%. What about the materials? Does a composite make a difference? Well, yes, it does. There are lower failure rates when we use conventional filled composite relative to flowable composite, and that's a 50% difference between those two. We find that when a tooth debonds from a bonded retainer and we rebond it, the failure rates are significantly high on the second rebond, around 21 to 28% of the chances of occurrence, and that's Tanner's 2012 study. And that's thought to be due to the difficulty in removing the previous composite, and therefore potentially we should keep a lower threshold for just replacing the wire when we get repeat failures. So what's the future direction when it comes to retainers? Well, in terms of braided stainless steel, Marie Cornelis was brave enough to say this is no longer the gold standard wire. There are side effects that we see reported, the so-called X effect or torquing effects or twist effect occurring. Now that happens between 2 and 4.5% of all braided stainless steel wires. To mention this could be for a number of reasons. It can be down to just made actively by the laboratory. It could be deformed on insertion by the operator or deformed by function. Now, what's on the horizons are the consideration for robot bent retainers, which have currently shown, at least in the early trial, 6 months follow-up showed less relapse taking place, and that was Shim's 2022 study. What about removable retainers? Well, the idea of having no gap in between removal of brackets and fitting a removable retainer. That's El-Shabini's 2024 study, where electronically removing the brackets and then therefore having the fit of the retainer at the same time as debond seems to be a clinically acceptable way to go forwards. So let's put all this information together and give some practical recommendations as to how to manage our retainers. Starting off with the Maxilla. For patients who have low relapse risk, a removable retainer should be sufficient. The materials we should consider using are polyethylene and polyuroethane, not polypropylene. In terms of high-risk patients, dual retention is recommended. What about the fixed retainer? Well, if the occlusion allows, we'll go for canine to canine retainer, but most likely it won't, and therefore lateral incisor to lateral incisor design is sufficient, unless there's high risk on the canines. The location of the bonded retainer should be slightly more gingival due to eliminating occlusal forces, but also accounting for the ever so slightly increasing overbite as the patients age. A great tip there from Simon Littlewood. In terms of recommendations from the mandible, well, for a low-risk patient, we should consider having a fixed retainer, and canine to canine should be sufficient. If it's a high-risk patient, then we go back to our default of dual retention, removable and fixed retainer. A lower canine to canine retainer is sufficient. We don't need to extend to premolars, even in extraction cases. Positioning of the fixed retainer should be slightly more incisal, as it allows for better cleansability and less gingival information. And that's Petros's study from 2023. In terms of our regimes and following up patients, this is what we should do as follows. At month 1, our fixed retainer patients should be followed up, and this is the greatest time point to have failures taking place. Our removable retainer patients at 3 months, and that's to help motivate our patients at that point. Now, the Clinical Practice Guidelines in Retention by Walters in 2018 recommended reviewing every 3 to 4 months within the first year, and 1 year of retention monitoring is necessary, followed by yearly checkups following that process. How can we improve our patients' compliance when 2/3 of patients stop wearing retainers at the 4-year mark? Well, a simple way to do this is to visually show patients at the time of removal of the braces or aligners what relapse could potentially be like. And we know that if we explain it to both the patient and the parent, we're much more likely to gain compliance and increasing 1.5 hours of wear on average. That brings us to the end of this episode. It's been an exciting few months. We've had some excellent guests on the podcast. We had Philippe Salah, the CEO of Dental Monitoring on, Jean-Marc Retrouvé telling us all about AI, and Chris Laspos and Guy Deeming about aligners. We've got some great interviews coming up. I've got Vincenzo D'Anto, who's behind both consensus statements on aligners this year, delving deep into that. And I'm really looking forward to a podcast coming up in December by Bjorn Ludwig, whereas I will be joining him as a guest in his audience for his Legends Farewell on the 13th of December in his hometown of Traben-Trabec. As always, please do subscribe and look forward to the next episode.